Imagine waking up one morning and noticing that the floor beneath your feet feels slightly wrong. Not painful, exactly, just different. A little distant, like you're walking on packed sand instead of hardwood. You mention it to your doctor, who orders a few tests, nods thoughtfully, and tells you it's probably just aging. So you accept that. You go home. But then the weeks pass and the feeling spreads. Now it's a buzzing in your toes that doesn't stop at night. Now it's a burning across the ball of your foot that wakes you at 2 in the morning. Now it's your fingers fumbling with buttons they've been fastening for 60 years. And somewhere in the quiet of those sleepless hours, a question begins forming that no one in any waiting room has ever answered for you. Why is this happening to me? And is it ever going to stop? If that question lives in you right now, I want you to know something before we go any further. You are not imagining this. You are not being dramatic. And you are most certainly not simply getting old. What you are experiencing has a name, a mechanism, and critically, a set of causes that most standard appointments never have the time to fully explain. What you are living with is peripheral neuropathy. And today, we are going to talk about what it actually is, where it actually comes from, and what that means for the path forward. Let's start with the scale of what we're talking about, because I think it will help you feel less alone in this. Peripheral neuropathy is not a rare condition tucked into the back pages of a medical textbook. Conservative estimates place the number of Americans living with it at somewhere between 20 and 30 million people. When you narrow that lens to adults over the age of 60, the numbers become quietly staggering. Studies suggest that somewhere between 15 and nearly 30% of people in that age group have measurable nerve damage in their extremities. That means in any group of 10 people your age sitting in a room together, 2 or 3 of them are feeling some version of what you feel. They just aren't talking about it. In clinical settings, peripheral neuropathy is consistently underdiagnosed, not because doctors don't care, but because the early symptoms are easy to attribute to other things, and because patients themselves often minimize what they're feeling, conditioned by years of being told that discomfort is simply part of growing older. This is what makes it a hidden epidemic. Not hidden in the sense of a conspiracy or a cover-up, but hidden in the sense that millions of people are quietly suffering through symptoms they've been handed no adequate explanation for, receiving treatments that manage sensation without ever addressing root cause, and gradually withdrawing from the activities that give their lives meaning, all while believing this is simply their fate. It is not your fate, but understanding why it's happening to you requires going one layer deeper than most conversations about this condition ever go. Your peripheral nervous system is the vast, intricate communication network that connects your brain and spinal cord, your central command, to every single part of your body it cannot directly reach. Think of it like this. If your brain is the headquarters of a large organization, your peripheral nerves are the telephone lines running out to every department, every office, every outpost. Those lines carry 2 kinds of messages: outgoing messages that tell your muscles to move, your heart to adjust, your digestive system to work, and incoming messages that report back on sensation, pressure, temperature, pain, position, texture. Every time you feel the warmth of a cup of coffee against your palm, or sense the slight unevenness of a step before you trip, that's your peripheral nervous system doing its job. Now here is where we need to slow down and look closely, because this is the piece that most explanations rush past. Each one of those peripheral nerve fibers, and there are billions of them, is wrapped in a protective coating called myelin. Myelin functions like the plastic insulation around an electrical wire. Its entire job is to ensure that signals traveling along the nerve stay fast, clean, and accurate. When that insulation is intact, a signal fires from your brain and arrives at your foot in a fraction of a second, precise and undiminished. You feel what you're supposed to feel, when you're supposed to feel it, at the intensity it's meant to register. But when myelin becomes damaged, when that insulation begins to fray or thin or break down, the signals start to leak, they distort, they misfire. A signal that should be interpreted as light touch arrives scrambled and your brain reads it as burning. A signal reporting on your foot's position in space arrives late or incomplete, and suddenly your balance feels unreliable in ways it never used to. A signal that should be conveying nothing, because nothing is touching your foot, fires on its own, spontaneously, and you feel a buzzing, an electric current, a tingling that has no physical source outside your own deteriorating nerve tissue. This is not your imagination producing symptoms. This is damaged wiring producing noise.
And here is what I need you to understand about how that damage happens, because this is the part that changes everything. In popular understanding, neuropathy is most commonly associated with diabetes, and it's true that chronically elevated blood sugar is one of the more aggressive ways nerve tissue gets damaged, because glucose at high levels is directly toxic to the myelin sheath. But the majority of people sitting with a diagnosis of peripheral neuropathy do not have diabetes, or if they do, that isn't the only factor at work. What the research increasingly shows us is that peripheral nerve damage is almost never the result of a single cause. It is almost always the result of several quiet, accumulated, insufficiently addressed insults to the nervous system, happening simultaneously over years in a body that was never given the tools to fully repair the damage as it occurred. The list of those insults is longer than most patients are ever shown. Vitamin B12 deficiency, one of the most common and most consistently overlooked drivers of neuropathy, particularly in older adults, particularly in those on certain long-term medications, directly impairs the body's ability to synthesize myelin. When B12 levels fall below optimal, the nervous system cannot maintain the insulation on its own fibers. The damage is slow, initially subtle, and by the time it shows up on standard blood work as a deficiency, significant nerve deterioration may have already accumulated. Vitamin D insufficiency, which is endemic in adults over 60 who spend less time in direct sunlight, plays a regulatory role in nerve inflammation that is still being mapped, but whose absence correlates strongly with neuropathic pain severity. Alpha-lipoic acid, an antioxidant compound the body produces naturally, but in declining quantities with age, is essential for protecting nerve tissue from the oxidative stress that accumulates in small vessel disease and metabolic dysfunction. When its availability drops, nerve cells are left without one of their primary shields against damage. There is also the role of inflammation, not the acute, visible inflammation of an infected wound, but the low-grade, systemic, chronic inflammation that modern medicine is only beginning to appreciate as a root driver of dozens of conditions we previously attributed purely to aging. Inflammatory cytokines, the chemical messengers your immune system releases during this chronic low-level activation, are directly toxic to peripheral nerve tissue at sustained levels. They degrade myelin. They impair the microcirculation that feeds nerve fibers. They interfere with the repair processes that would otherwise allow nerve tissue to slowly regenerate. And in adults over 60, this kind of chronic inflammation is extraordinarily common, driven by factors ranging from diet to gut health to sleep disruption to unresolved metabolic dysfunction, all of which interact with each other in ways that no single specialist managing a single organ system is necessarily positioned to untangle. Then there is circulation. Peripheral nerves are metabolically demanding. They require a constant, uninterrupted supply of oxygen and nutrients delivered through the smallest blood vessels in your body, the microvasculature. When those tiny vessels are compromised, even slightly, nerve tissue begins to starve. In the periphery, farthest from the heart, farthest from the lungs, that means the longest nerve fibers, the ones that travel all the way to your toes and fingertips, are the first to suffer. which is exactly the pattern you experience: the feet before the ankles before the calves, the fingertips before the hands. That isn't a coincidence. That is the geography of vascular insufficiency expressing itself through nerve tissue. Add to all of this the ordinary pharmaceutical landscape of chronic disease management in older adults. Several classes of medication commonly prescribed for conditions that are themselves more prevalent after 60. Statins for cholesterol, certain antibiotics, chemotherapy agents, proton pump inhibitors for reflux have well-documented associations with peripheral nerve damage or with the depletion of nutrients critical to nerve health. This is not a reason to stop any medication without medical guidance. It is a reason to understand that your treatment picture is a system, and that managing one variable without awareness of what that management does to others is how complex, multifactorial damage accumulates silently over time. Here is what this all converges on, and why it matters so much that you hear it clearly. The reason your neuropathy feels so difficult to treat is not because your nervous system is uniquely broken. It is because the conventional medical model, built around identifying a single diagnosis and prescribing a single intervention, is genuinely poorly equipped to address a condition that is almost always the product of multiple overlapping deficiencies, each one modest enough to fall below an alarm threshold on its own, but devastating in combination. Your doctor is not wrong. Your doctor is working within a system that allocates 15 minutes per visit, runs standard panels that were designed to catch acute disease rather than subclinical insufficiency, and reaches for the tools most reliably available, which in the case of neuropathy typically means gabapentin, duloxetine, or a referral to neurology, all of which address the symptom of pain without touching the underlying biology generating it. You are not failing treatment. The treatment model is failing to ask the right questions about you. That is precisely why this conversation exists, not to alarm you, not to replace the relationship you have with your physician, and certainly not to promise you a simple answer to something that has taken years to develop, but to give you, finally, completely, without the rush of an appointment, the framework that makes your own experience legible. Because once you understand why your nerves are sending distress signals, once you can see the full map of what has been quietly depleting and damaging the tissue responsible for your sensation and your balance and your independence, something important shifts. The helplessness begins to lift. The path forward stops being a fog and starts being a set of specific, addressable questions. And that, the movement from confusion to clarity, from passive suffering to informed engagement, is exactly where everything begins to change.